All right, everyone, we're going to get started. Okay. So welcome to our next installment of our Clinico-Pathologic Conference, our CPC. We've got our disclosure slides at the top, and we'll keep moving through. Today's case is the case of a 54-year-old female with history of carcinoid tumor, complicated by mets to the liver, as well as tricuspid regurgitation, as well as a recent pneumonia. And she's coming in with subacute progressive fatigue and acute progressive encephalopathy. But before we get into the case, let's introduce our expert here. All right, and Dr. Diffie. So you went to medical school at UT Houston, was here for residency, as well as here for fellowship, and he's an associate professor. History of carcinoid with mets, recent pneumonia, subacute progressive fatigue, acute progressive encephalopathy. What are some of your initial thoughts?
Right. So when I first started doing CPCs, I always spent a long time working up these one-liners, but I will tell you there are lies, there are damn lies, and then there's CPC one-liners. And I find that they are oftentimes designed to obfuscate rather than elucidate. If we were to kind of go through this, though, and approach it solidly, we would say this is a woman who has a recent, or I don't know how recent, but who has a history of carcinoid tumor with metastases to the liver and tricuspid regurgitation. And, certainly people with carcinoid tumor can have TR in association with that. But you don't want to, necessarily hedge too much immediately on one of these one-liners. And so you'd also wonder, in my world, any chance of there being something like pulmonary hypertension leading to tricuspid regurgitation instead. And, not immediately kind of pigeonhole into that, especially without like an Oxford comma after the word liver there. The recent pneumonia, a lot of patients I've met over the years have been diagnosed with pneumonia, and they're like, I get a pneumonia, and then I get better, and then I have another pneumonia, and then I get better, and then I have another. And a lot of times this is actually an underlying representation of interstitial lung disease that was either not recognized or kind of maybe presented more with like an organizing pneumonia, for example, and not like your classic UIP, NSIP kind of pattern. And then subacute progressive fatigue really doesn't tell me very much, if I'm being honest with you. I feel like it's kind of weird when patients come to me and they don't have fatigue. I think it's very non-specific. As a complaint, you'd of course want to like rule out insomnia, other kind of sleep disorders like OSA, could it be lassitude from depression that the patient's experiencing? Could it be hypothyroidism? Could it be adrenal insufficiency for some reason? But again, it's not a very specific thing, nothing that I'd really hang my hat on at this point. And then finally, we have this acute progressive encephalopathy. And that might be a little bit more meaningful to me. And when I hear encephalopathy, I kind of try in my mind to think of that as a big umbrella term, which includes many different silos. So, common things being common, you think about where they just put on some sort of like anticholinergic drug or something else that might kind of predispose to mental status changes. Do they have some sort of infectious process? Again, I think a 54-year-old would probably be able to handle something like a UTI without getting confused, but encephalopathy implies a very global process. In our world of rheumatology, we deal with people who more have maybe like an encephalitis, for example, which is kind of implies a more focal process and an inflammatory process as well that's going on. And I share a lot of patients with the neurologists here at WashU, and so I see a lot of people who have various kinds of encephalitides for various reasons. The differential is basically any rheumatologic disease, and there's some things that might kind of point towards one or another. So, there's things like neuropsychiatric lupus, which is certainly an important cause of encephalitis and encephalopathy in our lupus patients. We also have things like vasculitides, which can famously affect various parts of the brain. So giant cell arteritis can affect the posterior circulation of the brain. ANCA-associated vasculitis can affect the meninges and cause like leptomeningeal disease. Behçet's disease can affect like the anterior descending pyramidal tracts in something called the cascade sign. So we'll see. I think right now there's nothing I'd really hang my hat on, but we'll find out what's going on.
In terms of linking these, we've got kind of 4 different things going on: carcinoid, pneumonia, fatigue, encephalopathy. Are you using any of these as like big system axes? For example, you could link a pneumonia with fatigue or pneumonia with encephalopathy. Would you even think about like looping those, putting those together? Or
I mean, if it really were like a true bacterial pneumonia and someone had I could certainly see that causing like an encephalopathy unto itself. If someone is, maybe we're going to hear that the patient presents with a, an O2 sat of like 50, and that's why they're encephalopathic,
Cool.
right? I mean, I guess we don't really know yet.
Sounds good. So let's get some more history here. So she retired 6 weeks ago in the setting of her fatigue, as well as significant weight loss, poor PO intake, and some diarrhea. But her symptoms started about 6 months ago, and this history is from her husband, with progressive memory difficulties, and then it kind of got worse 6 weeks ago. Described as talking out of her head, not herself, not making any sense, saying words but not really sensical. No hallucinations or personality changes, but with some kind of changed behaviors. Not more specific than what we've got there. And then the impetus for hospitalization was a week ago. She had this even worse decline in her mental status. And then she was admitted to an outside hospital for pneumonia, found to be COVID positive, still treated with empiric antibiotics, and then transferred to Barnes. And then she was on the floor for a couple days, and then emergently got moved to the ICU for respiratory failure. She was intubated and found to have a low urine output.
Okay. I mean, I would say that this sort of flies in the face of the, recent pneumonia and the encephalopathy kind of process being associated with one another, because it's kind of hard to say that, I mean, it's kind of hard to say that COVID pneumonia for a week could explain 6 months of progressive memory difficulties. Although depending on what's causing the encephalopathy, maybe it's something that would in some way predispose to things like pneumonias or aspiration or something to that effect. So
How do you fit the weight loss and the PO intake?
Oh, I mean, I feel like my kind of gut assumption would be that in this, I guess we don't yet have a diagnosis of carcinoid tumor necessarily, but certainly that could be a concerning feature there. That is a lot of weight loss for rheumatologic disease. I will tell you, I have really never seen 100 pounds of weight loss from purely rheumatologic disease. I mean, with a lot of diarrhea, you of course wonder if there could be some sort of colitis, not necessarily just from, some other, not necessarily related with the neuroendocrine tumor that the patient has. Like, could they have ulcerative colitis or Crohn's disease, or could they have Behçet's disease with colitis or some other kind of colitic process? And that could probably cause, I mean, people can lose a lot of weight if they have chronic diarrhea that's truly, truly uncontrolled. But again, that's a lot of weight loss for any of the patients that I've seen from just pure rheumatologic illness. I would say I've never seen that, actually.
Quick question, history about the slide. Happen to know whether the weight loss was accompanied with hunger or before appetite?
Was it what with hunger or under
Or appetite, or was she hungry?
for appetite?
She did.
Yeah.
Okay.
All right. Got some more medical history here. So as stated, carcinoid, hypertension with the associated meds, IBS, and some mood symptoms, 2 prior surgeries, as well as a prior renal cell carcinoma, a little bit of rheumatologic history with our family history with her mother, as well as some medications here. And then finally, this was the job that she had retired from, working with adults and kids with mental challenges. And then recently had she has some pet dogs, as well as was fostering a rabbit, but otherwise kind of unremarkable.
Okay.
So as we would normally be on a rheumatology consult service, and you get your very long list of review of systems here. So as stated, still has the fatigue and the weight loss, but otherwise on review of systems, kind of head, ears, eyes and nose or broadly negative. Still has a cough after her pneumonia. She's anosarchic in her upper and lower extremities, as well as some diarrhea, but otherwise not too much.
Yeah. So, I mean, to me, the things that, we kind of already knew about diarrhea. If she has pneumonia, to me, it kind of reads for her to have a cough. The anasarca, I feel like I see that, in people who have had tremendous amounts of weight loss. They may have hypoalbuminemia that kind of, just sort of affects the fluid dynamics within their bodies and their ability to kind of retain things within their intravascular supply. But again, as a rheumatologist, you're holding a hammer, you're looking for nails, you wonder, could she have something like congestive heart failure, or more to our world, could it be something like a nephrotic syndrome that she's experienced here? Could she have some sort of cirrhosis as well? I guess we'll kind of get some information on that once we start seeing some basic labs here, but those would be the things that kind of stand out to me.
Perfect. We'll get our exam here to kind of further clarify. Otherwise, vitals. So this is prior to going to the ICU. So vitals, she was stable. Has her anasarca, edema in the upper and lower extremities bilaterally. She's got an ulcer, sacral ulcer, as well as her neuro exam. This is again prior to going to the ICU. Cranial nerves normal. Otherwise, she's attention's not really intact. She's like sort of trying to follow commands and wiggling toes. She does have weakness, objective weakness in the arms as well as in her legs. And then finally, her reflexes are 1+ and then absent, but perhaps a little bit complicated by obtaining them a little bit complicated by her anasarca.
Okay. And then one question, do we know whether the weight loss and poor PO intake, did that precede her confusion, or did they kind of co-occur with one another?
I don't recollect exactly, but it's roughly the similar time course of about that 6 months.
Okay. All right. I mean, so certainly I've seen people who've had like micronutrient deficiencies who can develop all sorts of unusual neurologic symptoms in association with that, like copper and zinc deficiency. And so something to think about in someone who's had such poor PO intake or B12 deficiency, or maybe another kind of consideration here. And
how does since that's not something we see too often, in terms of illness script and kind of temporality of that, how often do those, or how do those typically kind of present? So
yeah, I guess I would have thought that it would have taken time, you know, like you wouldn't just like immediately exhaust all of your
stores.
I mean, I guess B12 is water soluble, right? So it's something that you go through relatively quickly in your diet. But unless she had some sort of like inability to uptake B12, like a pernicious anemia or something like that, I think that would take, you know, a while to develop, or in someone who's just not tolerating PO. I see this stage 3 pressure ulcer, so it doesn't seem like she's been very mobile also. And I'm sure that her poor nutritional state probably is also contributing to that, as well as the ulcer on her lower extremity. Ulcers can happen with certain rheumatologic illnesses, like a vasculitis, for example. Pyoderma gangrenosum can sometimes be confused for an ulcer. So I'd want to see what that ulcer looked like, or at least a good description of it, like if it had a rolled border. And then she's got this kind of neurologic exam here that's rather prominent. I see that she attempts to follow command to stick out her tongue, but I guess by the phrasing, I kind of assume that she is not successful in her ability to do so. She seems to have a substantial weakness in her lower arms, but very limited mobility in her thighs and legs. She has some intact strength maybe in her very most distal part on her toes. So, you know, maybe would that be consistent with like a severe dermatomyositis or polymyositis or similar inflammatory myositis? Maybe. It seems very severe. I can say I don't see people with like 0 out of 5 strength usually. It's more like 3 out of 5 strength with their myosities. So we'll keep on rolling, I guess, and see what we see.
Perfect. So here's our basic workup. Abnormalities highlighted in red here.
Okay, so patient has a high creatinine of 2.2 with a normal value of 1.0. BUN is markedly elevated, far out of proportion to the creatinine elevation. And some of that may be related to dehydration and poor PO intake. You know, you also wonder, could there be something like an upper GI bleed and digestion of things, of blood leading to an elevation in BUN? The patient does have I guess, a mild acidosis as well with their CO2. I'm surprised their sodium is normal, honestly. And even though it's not marked as red, oh, is this just saying that everything on the LFTs is abnormal? So Looking through their LFTs, their total bili is elevated. It appears to be a direct bilirubinemia in this patient, which would maybe argue against something like a hemolytic anemia, for example, where you would see more of an indirect bilirubinemia. Their albumin is very low, as I alluded to before, in the setting of their poor PO intake. And so that might be contributing to things like their diffuse body wall edema. Their alkaline phosphatase is elevated as well as their AST and their ALT. Now, when you see an AST greater than ALT elevation, I consider that to be like a poor man's CK and aldolase in my world. And so when I see that kind of elevation in your AST, of course, you want to ask about like alcohol intake, which can sometimes also cause a similar pattern. But again, in our world, I really think about like a myositis. Is there something that's kind of causing aspartame transferase, we'll say, to leak out of muscles, where I guess it's relatively more concentrated in muscle tissue than ALT is. And so when muscles necrose or die or turn over for whatever reason, then we tend to see the AST elevate kind of disproportionately to the ALT. The patient's TSH, T4, ammonia, and EEG, I mean, honestly, I think they're all things that are basically normal in someone who's in this sort of setting. Has anyone ever seen an EEG that didn't show moderate generalized slowing and no seizures?
All right, we got our CBC as well.
Great. So the patient does have a prominent leukocytosis, neutrophil predominant, and apparently a normal diff too. They do have a slight anemia, which maybe would not be so crazy that I'd think you'd get a BUN of 90 out of that necessarily, if it were like a brisk upper GI bleed or something like that. Their platelets are normal, but they have a leukocytosis, right? And that's the big takeout here. And if they, assuming they didn't, again, they have COVID, I guess that's not all that unusual for you to have a leukocytosis. That's kind of the expected such CBC, I would say, in someone like that.
All right. Any now that we've got kind of, this is what we would have gotten in the first place, first place once they're coming up to the floor, what would be some of the kind of things that you would have started off with? And we'll
Right. So, I mean, I guess whenever someone's had 100 pounds of weight loss, I'd want to make sure that they had age-appropriate cancer screening also. Question, was there carcinoid tumor? Was it like a distant diagnosis of this, or is this more recent?
At least like 3 years.
Okay, all right. But I'd want to make sure that they had a age-appropriate cancer screening. Again, when I see all that kind of AST greater than ALT elevation, I'd really want to see what their CK and their aldolase look like. I'd want to look at a UA as well, make sure they don't have, evidence of myoglobinuria, like where the dip is positive for blood, but then you don't see any red blood cells on it. And that might kind of then imply that there's myoglobulin in it, and something where maybe you want to IV hydrate them more aggressively than you would otherwise. And then I guess, I'd want to make sure that they're getting IV fluids, nutrition, and, getting good wound care as well. But I guess diagnostic tests, for me, I'd start off with a CK, an aldolase, a UA, urine protein to creatinine ratio, BNP maybe.
Sure. So I actually don't think I included the actual thing here, but it's we don't have a CK and aldolase for you.
Okay.
But we do have
For
UA and
shame.
microscopy, as well as our protein creatinine.
Okay, so a little bit of proteinuria, but nothing to explain the degree of, oh wait, never mind, I'm sorry. The UA itself only had 1+ protein, but the urine protein to creatinine ratio, even though not necessarily in the nephrotic range, is rather elevated, I would say, in this patient. It's a subnephrotic, proteinuria that the patient has. And that may contribute, I would assume, to some degree to what we're noticing there. They have some very, very, minute pyuria with 6 to 10 white blood cells, and I'd make sure I ask them questions, about UA, UTI, things like that.
No urinary, dysuria or anything like that.
Right.
But also decreased urine output now that she's several days into her admission.
Now 7 days into her
several days into the admission.
Her urinary output starts to kind of go down over the course of her hospitalization. Okay, all right. Let's go back to our choice board here. I'm going to save room serologies for the end because I feel
I
like
agree with that.
I feel like that's less fun then. Let's do her infectious workup.
Sure.
What if I really messed with you and I was like, can we do the additional infectious workup first?
So this is the initial evaluation, and then we'll look at a couple other things before getting our LP results.
So patient has lactic acidosis. Their bicarb was 20 before, and I assume what we're saying here is that it corrects very quickly, with IV fluid resuscitation. She does have a positive nasal swab for MRSA, but her HIV, RPR blood cultures, I assume her T-spot, her toxo, Ehrlichia, Rocky Mountain spotted fever, Bartonella, B. quintana, histococcidio. I mean, I cause diseases at the end of the day. I guess she's a rabbit farmer.
She had fostered a rabbit recently.
She had a foster rabbit, and so we're checking for tularemia. Great. Some infectious disease nerd somewhere had a great time coming up with this, I'm sure. So this has been fun, but it doesn't really tell me too much.
Okay.
So let's go ahead and do, again, I don't think we're going to get an answer here, but let's just do her an additional infectious workup. Sure. Good, great. I think a lumbar puncture is a great idea in someone who's encephalopathic. It would really kind of help in my world. I'm not even looking at it yet, but it would kind of tell us, a lot of our autoimmune diseases present with certain changes like elevated protein, and sometimes they'll have like a lymphocytic pleocytosis on their LP. So let's take a look at it. So 5 days after admission, she gets a lumbar puncture. It has an opening pressure of 26, no nucleated cells, so no significant concern for like a lymphocytic pleocytosis that I alluded to before. She has 1.1 K RBCs, so kind of almost surprising she didn't have any nucleated cells. Her protein was 18, her glucose was high on this, I would say, and then her IgG to albumin ratio was elevated on this as well. We're still pending a evaluation of her for NMDA receptor encephalitis, but we have negative infectious cultures for all sorts of viral causes of encephalitis and meningitis, and they all come back negative. No evidence of any malignancy, at least a B cell population malignancy on her CSF, and her fungal AFB and gram stains are all negative too. So I guess, what I see here is that there is some increase in antibodies in her CSF kind of generally, but not necessarily an oligoclonal banding kind of process that would make you think of MS, for example. No evidence of lymphocytic pleocytosis, which would make, I think, things like a primary CNS vasculitis less likely, where that's seen in about 70 to 80% of people. Neurobuchette's a little bit less likely too. So I think that does kind of help answer some important questions as a rheumatologist and make certain things a little less likely on the differential.
How would those have shown up on this?
Like typically you would see someone who has an elevated white blood cell count, an elevated protein, and then when they did a diff on the white blood cell count, it would be like 60, 80% lymphocytes instead of, who knows what the diff would actually be, but there were 0 nukes, so it's not that, right? I think to me the standouts are the confusion, and I'm very tempted to do imaging, but I also kind of want to save that just a little bit. Let's kind of build up to things here. So let's do her cardiology studies here.
So unsurprisingly, she had an elevated NT-proBNP, and otherwise an echo that's not inconsistent with our original story here of kind of marked RV dilatation and RV dysfunction, torrential TR.
Torrential TR. Okay, great.
And bad PR as well.
Okay, all right.
Okay. Then we'll just to round out the evaluation, we've got our further clarification of the anemia.
Okay.
How are you processing this?
I'm honestly surprised no one did a ferritin or an iron panel.
I was a little surprised too.
So it's not a B12 deficiency. I guess we had alluded to that possibility earlier. I guess they checked niacin for pellagra. Is that what niacin deficiency is associated with? Dementia, dermatitis, and diarrhea. That's a great thought. And then folate deficient seems, I think that's normal. Her LDH was a little bit elevated, very nonspecific lab, right? I mean, anything that's causing cells to die might kind of lead to that. All right, let's do imaging. Let's go for the meat here.
Right. So this is from our abdominal radiology colleagues here. And you had mentioned kind of screening for occult or screening for malignancies and nothing obvious, at least on her. I don't think she had any like EGDs or anything like or colonoscopies before. Otherwise, we have her CT, chest, abdomen, pelvis, which shows chronic kind of liver mets and pseudocirrhosis, as well as some ascites and new severe body wall edema, as noted by the arrows. We've got evidence of prior edema versus pneumonia with ground glass opacities in the left lung, as well as pleural effusions, as well as this stable calcified mesenteric mass.
Yeah. So we're kind of walking through here. We have this calcified mesenteric mass. I mean, I guess the radiologist didn't want to be too helpful today, so they didn't tell us if that was maybe her primary there. But I think the fact that it's calcified to me implies some degree of chronicity to whatever has been there, because it doesn't happen overnight to develop calcification. And stable, I guess, implies that it has been there previously on prior imaging. The patient has had liver metastases as well, which we knew about ever since we kind of went through the one-liner, which are very helpfully pointed to with the red arrows. They have a just tremendous amount of kind of third spacing of fluid all throughout their body wall, but also ascites and kind of pleural effusions as well. Then they've got this kind of ground glassing of their lungs. And again, in the setting of someone who has known COVID, my assumption would be that this probably is like a viral pneumonia for this patient. We don't necessarily see on this particular image, I don't see subpleural sparing, and there are just like one little tiny bronchiole I think I could see that doesn't appear to have like traction bronchiectasis to imply maybe that we're dealing with like an NSIP pattern ILD, which can be seen in things like dermatomyositis or Sjogren's syndrome, or other kind of autoimmune diseases. So probably that's just reflecting her known COVID pneumonia, although it would be nice to see more of a detailed evaluation of what her scans look like.
Got our brain MRIs now a couple days into hospitalization here.
Okay.
So restricted diffusion in the right fornix, as well as adjacent anterior medial thalamus, which was new with associated T2 flare and hyperintensity, with their differential diagnosis as included.
Okay, so no abnormal contrast enhancement. So let's see, in the right fornix and adjacent to the anterior medial thalamus, new from prior brain MRI. Well, one kind of implies, I guess, that there was a prior MRI done. And so
she's had multiple prior to this at the outside hospital while they're trying to evaluate kind of the alteration.
For the cause of her altered mental status. Okay. So either maybe it was misread potentially at an outside hospital and our brilliant Mallinckrodt radiologist detected something that hadn't been there. But to me, it also would be a little bit weird if she was already encephalopathic and there weren't any changes on her MRI. So I think that's interesting. I don't think that that necessarily gives me a slam dunk diagnosis on anything there. You know, the kind of the geography and the kind of the area involved would be something that you could see, that kind of more midbrain involvement with the thalamus being affected could be reflecting Behçet's disease. But, you know, again, I feel like we're probably going to be looking at this next one to get our answers with our room labs. So let's go ahead and humor the rheumatologist and order all the labs.
Here we are.
Okay, so patient has a high titer ANA. They have a very high titer. Well, honestly, so when it comes to ANA, I very much so misspoke when I said that was a high titer ANA. I think a general rule of thumb is that an ANA of 1 to 80 and 1 to 160, very nonspecific, very low association with any necessarily rheumatologic diseases. And more commonly when I see that, my assumption is this is not something that is going to be a rheumatologic illness. 1 to 320 is maybe where I start to pay a little bit of attention, but it's really not until we start getting to things like 1 to 1280 or higher that I really start to kind of take it very seriously. So this ANA, if you just saw this as a referral sight unseen for everything else, then you would say not terribly exciting on its own. But the dsDNA is like,
how is it impacted by the recent infection, if at all?
Oh, that's also a great point. I mean, it would be a little bit unusual. So an ANA is an anti-nuclear antibody, right? And so it's not to a specific antigen that it's necessarily reacting to. It's to a large number of antigens that are found in a lyse nucleus. And so it can be a large number of things that it can target. And people with infections are going to have a positive ANA. People with chronic infections tend to have a lot of positive labs. And so things like hepatitis C and B, if you look at them, almost all patients are going to have a positive ANA. Something like 30% of people with hepatitis C even have like a rheumatoid factor. Like 20% of people with hepatitis B have a rheumatoid factor. These infections are major kind of confounders whenever we're trying to think about what is causing these antibody labs to be positive. The patient has a positive dsDNA, which is much more specific for lupus and can be seen when people have lupus nephritis. They also have a positive ENA, but then all the subserologies are negative. And let's talk a little bit about what an ENA is and what it's really telling you. So an ENA is short for extractable nuclear antigen. And when that gets run, so it's several different antigens that could be extracted, I guess, from the nucleus. And when it gets run by our machine, they essentially do a screening test, which is the ENA. And then they have, I guess, 1, 2, 3, 4, 5 of the most common causes of a positive ENA that they then directly report on to you. And then they check for all the other causes, which include things like a dsDNA, and then they forget it. They actually do not tell us that information. And it has to do with something to do with billing and trying to not, bill patients for doing all 11 of the, or 13 of the sub antigens that can be associated with a positive ENA. But I think the reality is in this situation, it just kind of creates a little headache for everyone and we're all stuck scratching our heads. Here, it's almost certainly because of the dsDNA that is positive, but there are other things like an anti-histone antibody, an single-stranded DNA antibody that can also be associated with a positive ENA when everything else is negative. They have a C-reactive protein that is very elevated and an erythrocyte sedimentation rate that is elevated. I would say maybe not to the same degree that their C-reactive protein is elevated, though. And some of that might relate to so when it comes to C-reactive protein and ESR, I think of your C-reactive protein as it happens quicker. It's almost like a CK, in cardiology, and your ESR kind of reacts a little bit more slowly than your C-reactive protein does. And so it's almost like a troponin in cardiology analogy. And so if you got hit by a bus and they checked the C-reactive protein in a day, that would start going up and your ESR might not go up for a couple of days after that. Not that I'm recommending it for anybody. So this would be very, very concerning for lupus, I would say. And given the kind of concern for neuropsychiatric lupus, given the kind of the encephalopathy that the patient was experiencing, you might consider doing things like running her CSF for anti-ribosomal P antibody, running her blood for anti-ribosomal P antibody, with the CSF being, my understanding is it's a very specific but not terribly sensitive test. It's seen in like 20% of people who have neuropsychiatric lupus, but when it is positive, is relatively specific for that kind of being the cause of her encephalopathy that she has had. And then again, I think given everything that we've seen with the subnephrotic proteinuria, the dsDNA that is elevated, and now her renal urine output kind of starting to decline, I'm honestly surprised we don't have pathology, because I would think we would probably do a kidney biopsy at some point on this patient.
So we've got a little bit more work up here.
Oh, interesting. Okay, so the patient came back with a we'll get to the very interesting thing there. They came back with a serum NMDAR receptor antibody that was, is that a positive at less than 1 to 240, I guess?
Yes. As well as the CSF of the NMDA receptor.
Very cool. Okay. And so, they did do an anti-ribosomal RNP. They did a CCP, they did a rheumatoid factor, and then a C4, all of which came back normal. However, we do have a very low, well, not a very low, but we do have a diminished C3 by several points with a normal C4, which to me would imply, well, a couple of things. One, interpreting complement studies is a complicated process, I will tell you. complement is an acute phase reactant. And so when people are inflamed and they have a C-reactive protein of 200, I'm going to think that their acute phase reactants are all going to go up a little bit just from the inflammation alone. At the same time, they are being ostensibly consumed because her C3 is low. But that is also itself a little bit of an assumption because many people have things like copy number variants that predispose them to develop lupus itself. And so that means they have a pre-existing mutation in their complement system that maybe keeps them from developing lupus itself. And we don't really know what the patient's baseline values are too in order to really make an educated guess. And so this is going to be helpful longitudinally for the patient. You know, down the line, we can see what happens once the patient's on treatment. And then if they start to have a relapse, you know, 2.5 years from now, or we're concerned that they're relapsing, we can check their complements again. And again, that kind of helps provide that longitudinal evaluation. But it does itself, unto itself, there's a lot of assumptions that we're making when we look at a C3 of 77 and we say, oh, well, aha, that's lupus right there. Because it's a little bit low. I think it is lupus here, though, for what it's worth.
How do you make sense of either the NMDA receptor antibody titers, both in the CSF and the serum? And do you mind talking about the entities of neuropsychiatric lupus as well as either autoimmune encephalitis or autoimmune encephalitis as characterized by NMDA receptor encephalitis?
Sure. So I never read the book Brain on Fire, but I've heard very good things about it that's associated with NMDA receptor encephalitis. Is that the book that I'm thinking of here? Sure. Yeah?
Sounds good.
Someone in the audience has read it and thought and agrees. Neuropsychiatric lupus is a very broad term, I would say, and it can include a large number of manifestations. People can have things like seizures, they can have strokes, it can include, some people kind of tautologically add things like, you know, CNS vasculitis associated with lupus into this kind of broader category. But a lot of patients, some people can present with very minute symptoms like depression is actually one of the symptoms of neuropsychiatric lupus. However, and so I guess it kind of is one of those things where it's everything and it's nothing too, right? It does imply that people need to be treated more aggressively, and
because of the severity of
because I mean, if it's involving your brain, then it has the possibility to do all sorts of awful things, like this patient has demonstrated. I mean, her life is ruined by it right now, right? And so people are typically treated with things like cyclophosphamide when they have really bad CNS lupus. They also have this positive NMDA receptor antibody that appears to be at is that less than 240 or greater than 1 to 240? They're trying to say that it's an incredibly high titer. Okay, yeah. So it seems to be much more concentrated within the CSF than it is within blood. Wait, am I reading that right? No, it's the other way around, huh? Okay.
It's very odd.
Yeah, that is odd. I do agree. I don't have a great answer for why it's so much less concentrated in their CSF than it is in their blood. Perhaps it has something to do with the ability of antibodies to cross through the blood-brain barrier would be my assumption, but I'm honestly not sure as a non-lupologist.
Okay. And then, well, I think we'll leave it there. Any other thoughts?
I've given you a lot of thoughts here.
Sounds good. Well, thank you very much, Dr. Diffie. That was exactly it. We got a new diagnosis of neuropsychiatric lupus presenting as NMDA receptor encephalitis. For this patient, for the rest of her hospital course, so she was started on dialysis for her volume overload as well as a uric AKI. They did consult nephrology, who actually ultimately thought that this was cardiorenal rather than lupus nephritis, as well as started on dobutamine.
You only get that much protein with cardiorenal syndrome? Is that Randy Chang just left, so never mind.
She got pulse dose steroids and then ultimately tapered, and actually did have some improvement in her encephalopathy. She also started on an MMF. She did get a brief course of IVIG, but no Plex, given the improvement in her encephalopathy. And then otherwise, she got her antibiotic for ulcers. They gave her vitamin supplementation, but ultimately passed away from multi-organ failure. And I have one question for you. So it was in reading through the notes, there was, a lot of diagnoses were getting thrown around of it. And the reason why I asked that last question was NMDA, receptor encephalitis and neuropsychiatric lupus. And then one note says this, another note says this, and it's kind of going back and forth. Does that matter, even making that distinction? And why is that? Because it sounds like it does have some implications for possibilities of treatment.
Yeah.
But do you mind just talking a little bit about that?
I'm going to have a little bit of pleading of ignorance about the association between the two of them here, to be honest. I would assume that it would be we would consult with our colleagues in neuroimmunology, and we would say kind of what's the lowest common denominator of treatment between the two of these kind of issues here. If it's something where they need to have, I understand why they would do things like IVIG or consideration of, plasmapheresis in someone who has this kind of antibody-mediated disease. I think when it's NMDA receptor encephalitis, I know you're supposed to look very closely for things like ovarian malignancies and other kinds of cancers, that there is oftentimes a perineoplastic process here, but I suppose it can also happen secondary to other things. There probably is an association between the two, and I'm just a little ignorant of it, to be honest.
That's perfect. Otherwise, my primary teaching point was kind of the variable nature that neuropsychiatric lupus can present with, both neuropsych as well as CNS versus peripheral involvement, primarily CNS. And that can be independent of kind of clinical or serologic activity, but if it does appear, it's typically kind of earlier on in the diagnosis.
Great.
But otherwise, thank you very much, Dr. Diffie.
Thank you so much for your attention, guys.
Good.